Welcome, everybody, to this session and roundtable discussion called FFR Wires Passé, Rethinking Assessment of Coronary Artery Disease. This segment is sponsored by Siemens Health and Ears, so thank you very much. And let me introduce myself. My name is Jeremias. I'm at St. Francis Hospital in New York. I'm the Director of Interventional Cardiology Research, and I'm also Director of the Physiology Core Lab at the Cardiovascular Research Foundation. I'm joined today by Dr. Michael Gallagher from Beaumont Hospital. He's the Director of Cardiac CT at Beaumont and also the Director of the Cardiac Fellowship, as well as Dr. Ziad Ali. He is the Assistant Professor at Columbia University and the Director of Intravascular Imaging and Physiology at Columbia, as well as my partner in crime at CRF, where he is the Director of the Angiographic Core Laboratory. And I think what we're going to talk about today is the advancement in coronary physiology. I think all of our focus is to maybe advance physiology from its current state as a purely diagnostic tool, as a yes-no type of tool to decide whether or not to treat, to use it more clinically during PCI for PCI guidance. And I will start off the session with using actually wire-based technology. Ziad is going to talk about angiographically based strategies to guide PCI. And then finally, Dr. Gallagher will discuss CT-based imaging and physiology assessment. And we're going to have a roundtable discussion at the end to go over these concepts and see where it takes us. I'm going to start the first presentation called Use of Physiology for Complex PCI. And as we all know, the question really is, when is imaging and physiology mandatory? And in my opinion, in left main lesions, in bifurcations, of course, calcifications, instant restenosis without any doubt, and then also in long lesions, especially in diabetic patients, all of these tools are critically important. And when we put these subsets of patients together, it's about 50% of your practice. So this is not an uncommon circumstance. And in my opinion, using physiology and imaging is not an adjunct to PCI. It really helps to determine what needs to be treated and what can be left alone. I think it's essential for CHIP PCI and also important to determine the treatment strategy, which is what we're discussing, I think, in this session, as well as ensuring a perfect result at the end. And so this is the current state of physiology. As you can see here, this is a LAD, of course, with at least 3 critical lesions and some diffuse disease with a significantly impaired distal IFR. But the question in this case, in my opinion, is not whether or not there is ischemia in the anterior wall. I think that's pretty obvious even looking at the angiogram. What the real question is, which of these lesions should be treated? Which of these lesions is actually contributing the most to the ischemic burden and has the best bang for our buck, if you will, for treatment with PCI? And so one of the ways of assessing this is to do an FFR pullback. The problem with an FFR pullback to assess serial lesions is that there's a lot of crosstalk between the lesions, such that the proximal stenosis influences the distal lesion and vice versa. And because of that, the assessment is actually quite difficult. This is one example of a serial stenosis in the proximal circumflex and the OM1, as you can see. The distal FFR is impaired at 0.74, and the pullback is done, and just proximal to that in between the 2 lesions, FFR is 0.91, above the ischemic threshold, and then all the way back at the proximal circumflex, it's 0.98. And so in theory, treating that more severe, angiographically more severe distal stenosis of the OM1 should deal with the problem. So this was done, a stent was implanted, FFR was remeasured, and now it actually went down. Now it's 0.69. And the reason it did is because now the distal lesion is treated, and so there is now a lot more flow going through the vessel by relieving the distal stenosis, and by increasing the flow, the proximal flow dynamics changed to the proximal lesion, which now became obviously also significant. And so that needed to be treated as well. And eventually, when both lesions are treated, FFR is restored to 0.96. But the bottom line of this is that it took multiple FFR pullbacks, multiple IV adenosine infusions, added about half hour to the procedure, and also significant patient discomfort. So that's not a practical way of PCI guidance. And so I think that's the reason why it's not really performed in daily practice. This is the concept, if you will, using a resting index pullback. And so the advantage of using a resting index pullback is that under resting condition, flow is pretty much preserved and kind of the same, if you will, up until maybe a 90+% stenosis. And so if there are serial 70% lesions, in theory, when we do a resting pullback, we can assess those lesions separately and evaluate the significance, and also importantly predict the outcome after treating one lesion. And so this is graphically depicted here. The distal stenosis is treated, and by doing so, when measuring hyperemic flow, you see how much flow is actually increasing by relieving the distal stenosis, just like in the case I showed you. And because of that, now changing the flow through the proximal stenosis and making it unpredictable. But in the resting condition, there's very little difference in resting flow between the two lesions, even when the distal stenosis is treated, and so we can actually make a much better prediction ahead of time. And so when we're looking at this original angiogram, what we find is that there is 3 step-ups. Lesion number 3, interestingly, which angiographically might be the most significant stenosis, actually only has a gradient of 4 points, so maybe not necessary to treat. The mid lesion has a 12-point gradient, but interestingly, the proximal LAD, which angiographically appears to be the least significant stenosis, has the largest step up of 15 points. And so the bottom line here is that treating lesion 1 and 2 would probably restore physiology, and we can leave lesion number 3, which I think is contrary to what most people would do just based on the angiogram alone. And in fact, what this resting pullback allows us to do is to differentiate diffuse disease from focal disease and identify a lesion that can be easily treated with a focal PCI versus more diffuse disease, which of course is more difficult to treat. And in fact, when we're looking at these case examples, the distal IFR of 0.86 is the same in each of the vessel, but as you can see here, the pattern of the pullback is completely different, such that in some of these there is a step up, in some of these there is diffuse disease, and I would submit to you that the treatment of these is completely different based on the pullback, despite having the same value in the distal vessel. And we can also now co-register these lesions to the angiogram. This is depicted here. The dots represent 1 IFR unit. So you see that there is a very significant focal stenosis of this ostial RCA, which is quite easy to treat, versus a more diffuse type of disease in this mid-LA proximal and mid-LAD, which requires more intense PCI. But the bottom line is we can now display on the angiogram the pressure loss when we do the pullback and really plan the procedure before we even put the first stent in. This is a case example of serial lesions where we actually do a pullback and assess physiology. There is no step up in the distal part. There is a step up of 9 points in this lesion in the mid RCA and 3 points in the proximal RCA. And so if we do this correctly, we can predict that we can shift the curve, if you will, by only treating the stenosis in the mid RCA, and should have an IFR of 0.97 when we eliminate the stenosis in the middle. This was an OCT-guided PCI to determine the landing zones, as well as the diameter of the stent. The stenting is performed based on the OCT, and the final IFR is exactly as predicted, 0.97. And what we see is that the gradient now is eliminated through the lesion, and we still have the residual gradient, of course, in the proximal RCA because that lesion was not treated. And so the bottom line in this case, as you can see here, is that we predicted exactly the outcome of the physiology, and these are the final angiograms with a reasonably good result. And so the bottom line of this case is that we have identified what needed to be treated. We left alone what can be left alone. We used physiology to guide the procedure. We used imaging to optimize the procedure. And then, of course, we used both to confirm that we have, in fact, the perfect result. The problem is, I think, that physiology still is significantly underutilized, partially because it's only currently used as a diagnostic tool, as opposed to a PCI guidance tool, which I think it can evolve to, especially when we're using some of these more non-invasive techniques we're going to hear about in a minute. We just completed the defined PCI study, which included 500 patients. All of these patients had impaired physiology at baseline and were treated with an angiographically based strategy. When the investigators thought they had a perfect result based on the angiogram, a blinded final IFR was performed, including an IFR pullback. When we're looking at these 500 patients, what we find is that this is the difference between the pre-IFR, if you will, and the final IFR. Some of these patients have enormous gain in IFR. When you're looking at the left, somebody who's going from 0.1 or 0.2 IFR to basically normal 0.9 or even 1 had a tremendous amount of benefit from the PCI. But some patients actually had very little benefit, where you can see here that I would say about 200 patients had very, very minor improvement in IFR, and some patients in blue even had a decreased IFR or less IFR after the PCI. And so obviously the result is variable. This is a case example of somebody having a stenosis in the distal LAD, which was treated successfully with PCI. And this is the corresponding physiology. IFR was 0.39 at baseline, obviously significantly impaired. Post-PCI, it improved to 0.74, which is, of course, a substantial improvement, but still significantly under the ischemic threshold of 0.89. And when we do this pullback, what we find is that it's a very good stent result, but there is a significant gradient proximally of a focal stenosis, which was intermediate based on the angiogram and was left alone. And I would submit to you, if that was known to the investigator, they probably would have treated this with a second stent. Similar situation in this case, a mid-LAD stenosis with a reasonably good final angiogram. This is the physiology, which again improves from 0.28 to 0.68, which is obviously substantial, but still a significant amount of residual ischemia. A quarter of the patient population and 24%, there is still significant ischemia after the angiographically optimal PCI. And most of those lesions are in fact focal, and only the minority are diffuse and more difficult to treatment. And when we're looking at the different segments, we find that about a third is within the stent, a third is proximal to the stent, and a third of the gradients are distal. And we calculated that, at least theoretically, if all of these focal lesions could be addressed with additional PCI, the residual ischemia rate could be reduced from 24 to about 5%. So let's move on to the second talk of the session. It's my pleasure to introduce Ziad Ali again, and he is going to talk about an emerging technology, angiographically based physiologic lesion assessment. Ziad?
Thanks very much, Alan. Why fix what isn't broken? We have tremendous data now, 15-year data from DEFER, which shows that we can safely defer PCI based on FFR. And we see that actually in the group of patients that had PCI performed, there was a higher target vessel event rate and a higher infarct rate. That, coupled with very strong efficacy data from the FAME series of trials, we found that in FAME1 and FAME2, we can improve clinical outcomes using an FFR-guided approach compared to an angiographic-guided approach, and using an FFR-guided approach compared to a medical therapy group. We also found that the efficacy of FFR in the long term is substantial, and moreover, that these clinical outcomes included the hard endpoints that we often strive for as interventional cardiologists and cardiologists. But what are the limitations of FFR? I think what we see and what we learned is that adenosine can indeed induce patient discomfort. We know that FFR takes longer than IFR, and time is of the essence in any cath lab across the world. And of course, there is an increment of cost. So if things can be done with less patient discomfort, faster, and more cost-effective, this would be welcome iterative technology. And I think that the instantaneous wave-free ratio was the first substantial iteration. The instantaneous wave-free ratio eliminated the need for adenosine and was found to be highly accurate and precise when compared to FFR, first in these two advised studies. And in large multi-center randomized controlled trials, assessing patients with intermediate coronary artery stenosis with invasive physiological pressure wire, these authors found in two large randomized trials that an FFR-guided approach and an IFR-guided approach were indeed non-inferior to each other. Subsequently, it was found that multiple non-hyperemic pressure ratios were likely to behave similar, whether it was IFR per se, whether it was an assessment of a resting index throughout all of diastole, or assessment of a resting index throughout the entire cardiac cycle. And this summary slide shows that there are now multiple non-hyperemic pressure ratios as well as hyperemic FFR. And as a result, there's multiple opportunities to use intracoronary physiological assessment to determine the stenosis severity of a lesion. And so we have lots of choices. And with these choices, we have FFR, commercially available DPR by Opsens, the resting full cycle ratio by Abbott, the instantaneous wave-free ratio by Volcano Phillips, the PDPA available on all systems, and the diastolic flow ratio available by Boston Scientific. But all things have to iterate, including technology. This summary slide from Patrick Sarus shows what type of iteration we've been able to make over the last 20 to 30 years. And you'll notice that as we go down somewhere around in the early 2000s, studies started to take into account how to potentially model flow within the coronary arteries using engineering tools and using physics in order to help us identify methods that may not require invasive physiological assessment. And what you'll see now, we're at this point where we're using CT FFR, which is going to be spoken about next, and of course, angiography-based FFR. So you may ask, how is this possible? Well, some of the earlier descriptions identified and described how this might be possible. Essentially, the first iteration was by creating a sort of mask net around the coronary artery. And by creating this simulated mesh or net, we could simulate the flow through a stenosis based on the preservation of law energy rules, and as a result, simulate what the pressure drop might be across this stenosis. As a result, we were also able to accurately and precisely mimic the FFR. So again, why fix what isn't broken? We went from FFR to IFR because it was cheaper, created less patient-related adverse effects, and was faster. But what if we had something that was even faster and even safer and perhaps even more cost-effective? And this is where angio-based FFR may provide a significant clinical value. We can see that the diagnostic accuracy, as I'll show you soon, for angiography-based FFR is very high with extremely high inter-observer reproducibility. You avoid complications by not placing an intracoronary guide wire. Instead, Simply performing an angiogram as part of routine coronary assessment can be used to make a physiological assessment. We can have faster and more simplified workflow. That means that we don't have to place a pressure wire in each vessel where we think there may be a lesion. Rather, we can do multi-vessel assessment extremely quickly. And something that Alan mentioned was post-PCI physiology, and while we all recognize its value, we also recognize there is a level of nuisance to this. And performing post-PCI physiology with a wire with a newly placed stent may be difficult and in fact may lead to its own set of complications. And of course, there's the potential for reduced consumables cost. This is a software technology, and as a result, it eliminates the need for ordering and restocking. So what do we know? What we know is that we have a large plethora of patients who have now been assessed in trials or registries by angiography-based FFR. And the summary of this is that there is an extremely high sensitivity and specificity for angiography-based FFR compared to conventional FFR. And this precision and accuracy really lays the stepping stone to us allow to use this in the cath lab on an ongoing basis. And if we look at some of the latest data published only a few months ago, we can see that the latest data from 5 prospective cohort studies shows an extremely high sensitivity and specificity and an extremely high area under the curve. And here on these slides, you can see the Bland-Altman shows very little systemic bias and shows, moreover, a correlation that's extremely high. So what's next for angiography-based FFR? Well, of course, with success, there is iterative technology, and this iterative technology is now being entered by a number of major sponsors. And we're now in the phase where there's multiple testing of different angiography-based FFR systems. What I'd like to bring to your attention is the Pi Medical system, which in collaboration with Siemens has performed the FAST trial series. The FAST trial series assesses angiography-based FFR in a systematic way, so-called virtual FFR or VFFR, such that it's encountering and understanding the majority of clinical studies and the majority of clinical practice, and now is in the stage of a FAST 2, which is currently enrolling patients. So here what I'd like to show you is how this really works. So what you might be able to see here on the left side is an angiogram of a patient with typical anginal symptoms. And you'll see that there's a moderate lesion in the circumflex coronary artery, but there's appears to be what is a severe lesion in the proximal left anterior descending. And in order to determine whether or not this technology actually works, we decided to employ virtual FFR and compare it to FFR in real world. And what you can see here is that the workflow for virtual FFR is actually extremely fast. And by simply identifying 2 angiograms greater than 30 degrees apart, selecting the appropriate equipment, and performing a simple center line based assessment of the coronary lesion, what we're able to do is have the software identify the stenosis. With some very simple corrective measures to ensure that we've accurately outlined the coronary artery, we're able to then help the software generate a potential 3-dimensional structure from 2-dimensional images, and therefore apply physics, and therefore apply the ability to construe a virtual FFR. As mentioned, in order to create this 3-dimensional structure from a 2-dimensional image, the images need to be taken in 2 separate views, at least 30 degrees apart. By placing the point of interest, we're then able to enter the patient's blood pressure and computationally determine the FFR. And here you can see in less than 60 seconds, we were able to accurately determine the FFR. And when I say accurately, the reason I can say this is when we compared this to an actual flow wire assessment in the same patient, you see that the virtual FFR is 0.72 and the actual FFR is 0.73. So when do we need to fix what isn't broken? Well, we need to do it when the new technology is easier, it's faster, safer, more comfortable, cheaper, more versatile, and can do everything else the prior technology could. Thank you very much.
Let's move to the final talk of the session. It's our great pleasure to have Dr. Gallagher join us this morning talking about the only non-invasive technique, CT FFR. Mike.
Well, good morning. Thanks, Alan. And it's a privilege to be part of this exciting course. My task is to share with you my thoughts on the non-invasive technique of FFR-CT. There are multiple non-invasive imaging techniques for cardiac imaging, as we know. On the left, the anatomic evaluation with coronary CT angiography is the most recent addition to the imaging modalities. On the right, physiologic techniques such as stress echocardiography, stress nuclear imaging, stress PET imaging have been with us for decades. And on the right, these techniques provide physiology or functional assessment. What I'd like to share with you today is that CT and FFR-CT is the only technique that will provide both an anatomic assessment as well as physiologic assessment of a patient's coronary anatomy. So let's just imagine for a minute that we're all going to see 100 patients this week with chest pain. And 10 of these patients outlined by the red dots are patients that have severe coronary disease causing their chest pain. The remaining 90 patients have atypical symptoms. We know that the current strategy of stress imaging, stress nuclear imaging, and stress echocardiography have average sensitivity. They'll detect about 70% of these patients. And so we'll have 3 false negatives, which is a significant safety issue. We also know that false positives are a very common occurrence with stress imaging, which often leads to unnecessary invasive coronary angiography and additional radiation exposure. So let me share with you a case to start this talk. This is a 59-year-old female with a calcium score of 292 Agatston units who had fairly atypical chest pain. She exercised for 10 minutes on the Bruce protocol, achieved 103% of her maximum predicted heart rate. And you can see here that her EKG showed some ST segment shifts that were consistent with an abnormal test. Her echocardiography, however, as shown here, demonstrated a normal post-exercise stress imaging. And so here we have a patient that has discordant EKG, mildly abnormal findings, and a normal stress echocardiography. So in this particular case, we proceeded with a coronary CT angiogram to better understand her predicament. She had, as you can see here, a 50% to 70% LAD stenosis, as shown here by the arrow, both mixed calcified and non-calcified plaques. So the question here is this physiologically significant? And if so, what is the next step? That brings us now back to what we've heard nicely over the past two presentations about the transition from coronary blockages or anatomic narrowings to coronary blood flow through invasive FFR techniques. And what I'd like to pose to you is that coronary CT angiography is also able to do the same, to develop a non-invasive flow profile map to assess both anatomy and coronary blood flow in a single hybrid imaging technique. So let's pause for a minute and talk about when is this being used. If we evaluate a coronary CT angiogram, and if the study is normal, or if there's less than a 25% diameter stenosis, these patients are typically treated medically. If, on the other hand, a patient has a greater than 70% stenosis, the majority of these patients with chest pain will go to the cath lab for invasive angiography with or without invasive FFR. A subset of patients with higher risk features with 50 to 70% will go to the cath lab, and a good portion of the 25 to 50% CT-derived stenosis will be treated medically. But it's this group in the middle that I would share with you, in that 40 to 80% range based upon CT angiography, that cause significant concern in terms of assessment. And this is where an FFR-CT is quite valuable. This is where you'd like to get a flow map to look at the FFR-CT values distal to the lesion as well as in the terminal vessel and compare the anatomy together with the FFR correlation. Now, this is an example of 2 patients, patient A on the top and patient B on the bottom, that both have seemingly similar degrees of calcification and stenosis in the LAD. You can see on the top, the FFR-CT value is 0.86, and this is verified by an invasive angiographic and FFR assessment with a similar invasive FFR. The patient on the bottom indeed has a positive FFR-CT value shown here, and again, angiographically, this was confirmed with an invasive FFR. So both of these calcified plaques were well assessed by non-invasive FFR CT. Now, we've talked about when to assess, when to use FFR CT in patients with moderate stenosis and calcification, but you do need to have either high-quality images, satisfactory or excellent images shown here. The majority of patients with marginal images shown here also are adequate for FFR CT assessment, but we need to be careful not to send patients, as shown here on the right, with poor image quality, those with motion, those with significant misalignment, and in particular, those with bypass grafts and metallic stents in the left main and LAD or multiple vessels cannot be sent for FFR assessment of their CT anatomy. So we've heard very nicely today about what FFR is. Invasive FFR is indeed the gold standard for identifying functionally significant coronary disease. There's been a decade or more of research that has nicely shown that if indeed you use invasive FFR values of less than 0.8 to make final decisions to guide revascularization strategies, the overall safety and outcomes are indeed better. So let's get back to our case. How can a cardiac CTA provide similar physiologic information? And if you can see on the left panel, I'm walking through this assessment. In the proximal LAD, the value is 0.93 by a FFR CT. As we go distal to the bifurcation of the LAD into the diagonal system, you can see that the vessel entirely becomes ischemic, with values ranging between 0.7 and 0.76. Now, if we look at the angiographic comparison in this case, you can see that this patient indeed had an occluded circumflex shown by the FFR CT in the top right panel, as well as shown in the bottom left panel by the yellow arrows. The invasive FFR values shown here by the white panels indeed revealed very similar invasive FFR values to the FFR CT shown in the top right. This patient underwent circumflex stenting, bifurcation LAD, and diagonal stenting as shown here. So indeed, the validation studies have shown that FFR CT works. In over 1,000 patients, there's been high diagnostic accuracy. The most recent accuracy study published in the Journal of the American College of Cardiology, called the Pacific trial, compared over 200 patients that all underwent invasive angiography, invasive FFR, CT, FFR CT, and PET perfusion imaging, with the highest area under the curve, the FFR CT analysis and assessment. So indeed, it was the most accurate, the most sensitive, and the most specific technique. So we know that direct imaging of atherosclerosis to image the actual disease process is the preferred test to detect coronary disease. It has a high sensitivity. But the Achilles heel of coronary CT angiography has been these intermediate stenoses and those with significant calcification. And this is a situation where FFR CT improves the specificity while maintaining the excellent sensitivity that CT angiography enjoys. So how do we go from these anatomic static images on the left to this beautiful flow map on the right, from a typically acquired CT without additional imaging, with no additional radiation, and no administration of medications? We have to focus on some scientific principles that allow this to happen. Number one, the resting coronary blood flow is proportional to the myocardial mass. And the mass, as you can see here on the bottom CT images, is very nicely depicted with high spatial resolution by coronary CT imaging. The resistance of the vascular bed is also inversely proportional to the size of the feeding vessel, and these vessels are beautifully analyzed by CT angiography. This, together with advanced 3D modeling of the blood flow, is required to solve these governing fluid equations and allow us to go from anatomic images on the left to physiologic images on the right, and to create a patient-specific model of coronary flow and pressure. So indeed, the future coronary CTA is the preferred pathway in the UK with the NICE guidelines. The imaging of coronary CT angiography is also elevated in the guidelines in the European Society of Cardiology, and it's gaining significant traction in the United States. So if we look at a typical coronary artery disease diagnostic workflow on the left, stress imaging, stress echo, stress nuclear often lead to differing and limited data sets and information, which leaves the clinician often uncertain how to proceed with further testing. Additional tests are often done, and the decision to go to the cath lab is often made with suboptimal imaging and information. If indeed we switch to a one-stop shop for a significant portion of patients and begin with CT angiography to detect if there is coronary disease, And if there is disease, to then send these images for FFR-CT analysis to derive a flow map. We then do not need any additional testing or information, and we can make a binary decision to proceed with either medical therapy or catheterization. And this decision is made using both anatomic and functional information. So we've seen over the validation studies over the past several years that it is indeed safe to defer invasive coronary angiography for patients with FFR-CT values of greater than 0.8. And we've also seen, based upon the platform study, that the invasive coronary angiography rates decrease significantly with a CT-based approach, and there is no change in revascularization rates comparing the two cohorts. So indeed, the future is exciting. Planning PCI interventions can also be entertained by CT angiography and FFR-CT. You can see here in the top right, the severe right coronary artery stenosis modeled nicely with FFR-CT. A virtual stent was placed. We were able to look at the size and length of the stent and accurately predict the stent that was required via angiography as shown here below. So indeed, I think the future of risk assessment should begin with the CT first strategy to evaluate anatomy. And then FFR-CT allows us to evaluate the functional significance of these anatomic lesions. It allows us to look at whole heart quantification and characterization of atherosclerosis and to identify lesion-specific ischemia. So both coronary CT angiography and FFR-CT is the only non-invasive cardiac pathway to provide both anatomic and lesion-specific functional information in a single imaging test. The addition of FFR-CT or physiology to CTA has better diagnostic performance than any other non-invasive test, and validation studies have been very promising. Indeed, CTA and FFR-CT analysis is a one-stop shop, a personalized approach to cardiac testing that helps identify the optimal treatment path. So thanks very much.
All right. Let me start with Ziad. In a few minutes we have left for the discussion. So I guess I have a two-part question, if you will. The first is, I wanted to see your opinion on this kind of transformation of physiology from a pure diagnostic tool, treat or not treat, if you will, to a PCI guidance tool, similar to what I showed in my presentation with this resting index pullback. Do you think that's a concept that will stand in terms of, moving forward with PCI? And then the second question, if that is the case, can the non-invasive angiographically based assessment kind of do the same thing, maybe easier, faster, with less risk? And is that something we're going to be using on a regular basis?
I think the title of this seminar really highlights that wires may be passé. We, in the past, used to consider imaging, for example, intravascular imaging, to decide how to treat, but use physiology to determine whether we should treat. But now what we're doing is we're essentially hybridizing those two things that you actually mentioned, imaging and physiology. And with the sensitivity and specificity of these modalities, both non-invasive and invasive, and in the planning tools that are available, I really can't see a very strong position for wires in the future to come. Now, we should mention that there are certain caveats to these technologies. For example, angiography-based FFR needs to be validated in specific patient subgroups, and it takes time to catch up on 30 years worth of data. But as I mentioned in my talk, that we iterate in order to make things easier, faster, more cost-effective, and ultimately have the same clinical outcomes. So I think that it's invariable that imaging-based assessment of physiological stenosis is the way of the future.
Part of the problem I have with the technology, at least currently, and I'm sure this is something that will be solved down the road, is just very cumbersome, right? You have to either scrub out or somebody else has to do it. You have to wait multiple minutes. You have to take different angulation. You have to analyze the imaging. So it sounds good, of course, in a quick presentation. I think there's a lot of work still to be done to make this mainstream.
Actually, those things are relatively easy to fix. right? We're talking about logistics, cables, fixing sensitivity and specificity, accuracy and precision is much more difficult. So I'm hopeful still that we're in the home stretch.
Let's talk about CT FFR for a minute. My concern is a little bit from my read of the data, and this is what I want to get your feel for. I think CT FFR is very helpful kind of on the two extremes. If you have a somewhat mild lesion, if you have a more severe lesion, certainly can be very helpful. My experience has been that when you have an intermediate lesion, somewhere between 50 to 70%, the numbers are also kind of all, in the borderline range for CT FFR. And I'm not sure correlate that closely with invasive FFR. And so my concern for that patient population, what are you going to do in those cases? And what is your confidence that you have the right number based on CT FFR?
CT FFR is done to CT has helped fix the precision. We know that CT is the best test with the highest sensitivity, bar none, to image patients who have atherosclerosis. So it is the safest test with the highest negative predictive value. I don't think that FFR CT is going to completely be 100% accurate and have a perfect a flow map assessment for every lesion, because it's very important that we know how to correlate the FFR CT with the anatomy. Are we looking distal to the lesion? Are we looking in the terminal vessel? And just like in invasive FFR, there are some gray zone areas. In CT FFR, there are also gray zones. And we have to be very careful with how we deal with those particular patient subsets. So I think there are some patients in the middle, as there are in the invasive lab, that still we have some modest accuracy. But the CT FFR assessment has substantially improve the accuracy of a CT-guided approach. And so I do think it is a gold standard technique for non-invasive assessment.
I think it certainly is a big step forward, and I think there has to be also some kinks worked out here. But overall, to me, it looks like it's a much better strategy than what we currently practice in most circumstances, which is, nuclear stress testing and so forth. So Ziad, how do you see the two kind of work together? Are you ordering CT FFRs at this point?
Yeah, thanks, Alan. We have definitely implemented CT FFR clinically and are using it. I think I envision a workflow model where patients who have stable coronary artery disease undergo CT with the addition of FFR as appropriate, where Michael mentioned if they have intermediate lesions, before they come to the cath lab. And then using the planning tools, since we already have physiology and anatomy, this will turn something into like a TAVR, where we've got everything planned before the patient comes in the room, so that we're really providing a targeted therapy rather than sort of a hodgepodge of what do we do now? Let's go and roll this machine in. Let's bring that machine in. But it also ties beautifully to the unpredictable nature of coronary disease. In patients, for example, for an acute coronary syndrome who come in, we treat the culprit lesion, and there are intermediate or moderate lesions. We may perform angio-based FFR on those lesions to provide an assessment of what needs complete revascularization. So I think the workflow, again, wires are passé, and I think we're moving towards both non-invasively and quote-unquote invasively imaging-based approaches.
Let's see if that happens, but I would imagine, especially also with the advances in AI technology, that this is a very, very good possibility. So let's give the final word to Mike here. So if you have a crystal ball in 5 years or maybe 10 years' time in the US, what do you think the adoption of CT will be, and CT FFR in particular?
I think that we'll be moving rather rapidly over the next few years, the United States, towards a CT-first strategy. So I think I'm quite confident about that new approach.
All right, so I think we have some nice outlooks for the future. We'll see what's going to happen. At any rate, I think we're going to bring this session to a close. Thank you so much for joining us. I hope you enjoyed it, and we'll see you soon. Thank you.